Hi, this is Heidi Nelson, CEO at Duffy Health Center, and welcome to this edition of Duffy Doings, our show about health and homelessness on Cape Cod and what's going on at Duffy Health Center. Today, my guests are some of our senior staff from Duffy Health Center. Anna Marini, who is our Associate Director of Quality Improvement. Welcome, Anna.
Thank you, Heidi.
Pat Cawley, who serves as Senior Director for Program Services. Welcome. And Dr. Wesley Klein, who's our Medical Director. Welcome. So today we're going to talk about the opiate crisis, but we're going to take a little bit of a different approach, a little bit of a different angle. Look at people who are living with addiction and how we approach that and how we treat addiction at Duffy Health Center, what kind of wraparound services we're providing, and what we've learned over the years through providing treatment services to people who are addicted to opiates and how it's improved our model of care for all of the people that we've served at Duffy Health Center. So again, in talking about the opiate crisis, opiate pain medication and other kinds of illegal opiates create an addiction because they create a feeling in the brain. There's lots of dopamine hormones that are released, and so they create a sense of euphoria in the brain that makes the user want to go back and try it again and try it again and try it again. What happens, though, after repeated use is that the brain gets used to that level of drug and needs more and more and more in order to reproduce that feeling of euphoria. And eventually, this creates the situation where somebody is dependent and addicted. Opiate use disorder is the name of the clinical term for opiate addiction or abuse, and the federal government says that over 2.1 million people in the United States, it's about 1%, almost 1% of the population has an opiate use disorder. Last year, in 2017, the Federal Health and Human Services Department declared a public health emergency around the opiate crisis and developed a strategy to address it. At Duffy Health Center, we've adopted many of those evidence-based practices that have been promoted by the federal government, and we've been helping many people over the years with opiate use disorders and other related illnesses by taking a holistic approach to their care. We keep adding programs and services to our offerings, and we strive to provide the most comprehensive care that we can to the patients that we serve, all under one roof. And what we call that is the patient-centered medical home, and this is a certification that's awarded nationally, patient-centered medical home, and Anna is our point person on that. Can you explain for the audience what the patient-centered medical home is?
I'd be happy to. Since 2014, we've been recognized and certified as a patient-centered medical home, and what it means is that we really try to focus on holistic care. Every aspect of what our patients need on site under one roof. So we provide exceptional patient care, integrated care for mental health services, opioid use disorder services, as well as other kinds of community service and housing assistance needs that our patients may require. We coordinate our care by using shared medical appointments whenever possible, and that's an area that we're trying to expand in lots of different chronic care areas. When we use that kind of a model, we have a 2-hour appointment usually on some periodic basis, once a month, every couple of weeks, and during that time it's one-stop shopping for our patients where they come in and see medical providers, behavioral health providers, substance use treatment providers, and possibly case managers depending on their needs. And in that way, we're able to really take care of everything for them. We also like to arrange for specialists to come on site to Duffy to make things as convenient as possible for our patients. It's our goal here for our patients that we respect their unique needs and circumstances and to ensure that they have access to quality health care.
Right. So this is not a simple thing. This is a really extensive checklist. It's on the computer. There's lots of standards for how we have to do a lot of different aspects of our care. So when we refer somebody out to a specialist, or when we refer somebody to go get a test, we don't just cross our fingers and hope that they go. We have to follow up and make sure that they go. We have to have systems that if somebody has an issue in the middle of the night and they want to try to contact us rather than going to the emergency room, they can call us and we can connect them with a provider in the middle of the night. And those are just a couple of aspects, looking at quality of care, what are our scores as it relates to diabetes, how do we use that information to improve the quality of care that we provide. It's very extensive, and it's a big job that you have to do to keep track of all of it.
It certainly is, and it requires an enormous amount of teamwork among the clinical and operations staff. And we're very proud that we've been able to achieve this and continue to work on all our systems and have a lot of tracking mechanisms that we use with electronic health record, which helps us to be able to be successful in keeping track of all the patient care needs for our staff and patients.
Right. Very good. Very good. So getting back to the opiate crisis, Dr. Klein, talk about how we experience that at Duffy, and how does Duffy fit into the treatment picture?
Well, because homelessness has a component of usually some sort of a mental illness component. Also, there's a lot of psychosocial issues. We have a high proportion of patients that suffer from substance use disorder, and the most prevalent one now is opiate use disorder. As Heidi said, often people start with prescription medications. Sometimes they start with their friends giving them or providing them opiates. And what we've learned is they're very, very addictive. There are some people that can become addicted only after a single use. What that's led to is tighter prescribing recommendations and rules, and again, trying to keep better tabs on these things by the federal government, things like that. But what we have is we have a huge number of people that are now have this condition, and we have to figure out what we do to help them become productive citizens, what we can do to get them back to their families or get them back to more of a healthy, productive life. And we do that in a variety of different ways.
And you hear that over and over again from our patients, how they had really hit rock bottom, and we help them to regain their lives and get their lives back. So it's very gratifying work, but can also be very frustrating, I'm sure.
It can. They say it's a relapsing remitting disease, meaning that you expect people to relapse and you expect them to have slips over time, but most of the time, if they can stay with a program, those become less frequent, and then at some point you hope that they can remain in remission from their opiate use for years or decades, and that is possible, but it's difficult.
And we treat people for opiate addiction even if they're housed. At Duffy Health Center, our special mission on the Cape is to work with people who live on the street or in the shelter. Many people have lost their housing and move in with friends and family. But with addiction in particular, we know that people can be just a step away from falling into homelessness. So we do treat a number of people in our addiction treatment programs who are housed, who have jobs, but are just on the precipice of kind of spinning out of control. So one of the programs that we offer in our community here is the medication-assisted treatment program. When people think of substance use treatment, they often think about going into rehab. That's what we hear a lot, and people concerned about lack of resources for the people who live in Barnstable County, that there aren't enough treatment beds and 28-day rehab programs. But one of the things that we know is that we can apply other types of treatments so that we can just completely bypass that system by prescribing medications on an outpatient basis. And Suboxone and Vivitrol are two of those medications. So you want to talk about what those are and how they work?
Sure. So we call this MAT, medication or medical assisted treatment. And it's the idea, it's based upon the idea that these opiates have really changed a person's brain chemistry. And often what happens is when people do the classic detox rehab for 28 days, the relapse rate is incredibly high. When you sometimes provide a medication to try to mitigate some of those chemical imbalances that have occurred over years of use, you can actually be more successful. So the two medications that are used is, one is called Vivitrol, which is an injection once a month basically, and it works like a opiate blocker medication, and it helps basically someone stay off of opiates. We use they don't like the term anymore, but stay clean. And the way it does that is it blunts the opiate effect, meaning people don't really get high. And we also use Vivitrol for alcohol, believe it or not. It works on the same sort of chemical pathways. And for those folks, it works fairly well. We have of our 300 MAT patients, about 30 are on the Vivitrol program. Most people, though, opt for something called Suboxone, and Suboxone is what we do most. So what Suboxone is, it's buprenorphine. It's a opiate agonist antagonist, and what it means is it has some properties of an opiate, like oxycodone or fentanyl or heroin, but it also has some blocking effects. So what it allows people to do is stay out of withdrawal but not get high. And often people that are addicted to opiates talk about Suboxone making them feel normal. In other words, they often they try to not use medications. They'll try to not use things like Suboxone or heroin, but depression, anxiety, underlying mental health issues sometimes come to the fore, and it can be difficult. Sometimes by using these medications, we can actually help people live very normal lives. And so, like I said, the vast majority of our patients are using the Suboxone type medications, which are highly regulated. I think sometimes Suboxone gets a bad rap. People sometimes think about it as a drug treatment clinic. People get their scripts, and then they go off and do what they want. We try to do a wraparound type of program. We provide very short scripts. What I mean by that is at the beginning they'll get no more than a week at a time. They have to engage in some sort of a behavioral therapy component. They have to meet with our peer navigator type people. So it's not just giving them the medication, it's medication assisted therapy. Okay, so we're trying to use the medication and allow them to experience time in recovery, get their life back together, and move on.
Right. We could do a whole show about Suboxone and the issues with Suboxone. I know there are interesting policy proposals out there for starting people in jail and prison on Suboxone. There are concerns about that because law enforcement often thinks that there's diversion, is a possibility, and people who aren't taking it for treatment can experience a high from it. So there are some issues there that need to be overcome. But in Rhode Island, for example, people who are on Suboxone outside of jail are continued when they're inside jail. People who are addicted outside of jail can be prescribed Suboxone inside of jail to control their cravings and really get them on the treatment path. We also work with the Barnstable County Jail. Actually, that's why we started Vivitrol. We weren't doing Vivitrol until they asked us to. So they were doing the shot 2 or 3 months before
It's a month. They
people
give
leave?
it
Oh, just a
usually
month.
within a
Okay.
month before, within that 4-week period, and then the idea that they're supposed to come out and we're supposed to give them the second shot.
Right, right. So lots of partnerships there.
Right.
And part of the evidence-based model that's promoted by the federal government is, as Wes said, the wraparound services. We want there to be a lot of MAT available in the community, but not all primary care offices are equipped to provide the full range of services that are really part of the evidence-based model. They may just make a referral to a therapist and hope that it works. But at Duffy, we're fortunate with federal and state funding that we're able to have a robust model that includes a therapist embedded with the MAT team. And Pat's the supervisor of that person. You want to talk about Louisa and what she does?
Okay. When you mentioned embedded, I want people to understand it means that they're actually, the therapist office is on the same floor right beside the nurse, the addiction nurse, and in between the doctor. The MAT team consists of a couple of nurses who specialize in addiction, an MD, a medical assistant, the therapist, and a recovery support navigator. And the therapist on the MAT team does traditional therapy. She does the assessments and set goals and does interventions with people. But what the embedded therapist adds to the team is the immediacy,
Right.
that she's right there. So if somebody comes in and looks like they're not having a good day, it could be a quick 5-10 minute conversation with a person, and then maybe, okay, we need to try something different.
Right.
Each member of the team brings their own expertise, and I know you and Wes have both talked about holistic care. Everybody brings their perceptions through the lens of their discipline. So what the therapist brings is the psychosocial issues. She can bring that to the team, whereas the nurses are focusing on the addiction. But everybody working together really does the best for that client that's right there. The embedded therapist role isn't as predictable because you never know what's going to happen that day. You might have your regularly scheduled appointments, or there might be a crisis that you have to attend to. It's really a great support for the clients that we serve and also for the rest of the staff, because it's knowing that you can do the warm handoff to another professional. You know, if you have people lined up and you have to attend to their medical needs, it's nice to have somebody to say, okay, I know the psychiatric piece is going to be taken care of by somebody who knows what they're doing.
And it really is a different kind of practicing for therapists. I would think you'd have to hire for somebody who likes that unpredictability.
Absolutely.
When we think of therapists, we think of, you know, I'm having therapy with you, and here's my diploma on the wall, and you know, maybe a couch or you know, whatever, and talking about your depression. But this is, you know, really being available to the medical team. Dr. Klein, as much as Dr. Klein would love to sit and talk with somebody about their depression, he's got 5 patients backed up in the other rooms or out in the waiting room, and thinking about the linkages and the connections to ongoing treatment that those people need, that Louisa can provide that kind of connection. And Dr. Klein's very happy to know that we're going to have a second embedded therapist soon. Do you want to talk about that?
Sure. That person will work on the medical side, and similarly will be available for the traditional type work, but more importantly for somebody, for instance, is having difficulty sleeping at night. Doesn't really need to get into therapy, but isn't it nice to be able to pull somebody in quick and just kind of like talk about, okay, what do you do before you go to bed? And just give some tidbits on that. Or somebody's having some family issues. They're not asking for therapy, but it would be really helpful if they could talk to somebody for 20 minutes to an hour just to put things into perspective. And we know that there's a lot of overlap between medical illnesses and psychiatric and psychosocial. So again, we'll beef up the team and be able to provide more support for our clients where it's really necessary.
It's often where I'm trying to talk a patient into seeing a therapist, and making them go upstairs seems like a barrier that they'll never cross.
And there's still stigma.
There
There's
is.
still
So
stigma,
having
so-
someone I can bring in right then and there is very useful,
Right.
because I don't have to make them make another appointment.
Right.
they can just do it right then and there. So
And
it's
then-
going to be good.
And it might be 4 or 5 sessions before the person is really ready for
Yeah,
therapy. But it's a
exactly.
building trust, and it's getting to know people and them getting to know the therapist as well. So it's a process.
Well, and it's really interesting what you added about sort of the short-term, you know, and just needing to talk to somebody who may have tips and tricks,
Right,
you know, that
exactly.
can address a particular issue or can assess somebody's willingness and readiness for treatment. How many people have you referred to behavioral health and then they no-show?
The majority.
I hope not.
I mean, no, but I mean, it's very common where
Yeah.
you try,
Right.
but they don't
Right.
make that connection.
Yeah.
Right,
They
and
don't
having
do it.
them come in for an intake, and
Right,
then,
they don't
you know,
do
they
it.
miss that appointment, or they do the intake, but then they don't follow through with
Right.
therapy. But it can be very comfortable just to talk to
Right.
somebody in the exam room, so
Exactly.
that's an advantage.
Yeah, definitely.
So I'm sure you're looking forward to that. yes.
Absolutely. Absolutely.
So that'll be a great addition to our model because it's that immediate
Right.
connection
Right.
that makes the big difference, I think, for people. And also, there's a value in the event that a patient is having a more major crisis.
Oh, it's
Again, there's
terrible.
somebody
Right.
right on site that can spend the time on those issues and
We've had many
be support.
patients that, because of our patient population, we've had many patients that have had deaths in their family and are in deep, deep crisis. And it's very powerful to have someone to help them right then, right there, when they're going through
Right.
that sort
Yeah.
of awful thing.
Right.
You know.
So
Well, and while we're talking about behavioral health and substance use and mental health issues, there's a component of this patient-centered medical home model that is, I believe it's Massachusetts specific, but that it's going to be spreading across the country. We
Right.
were sort of the initial site for PCMH Prime. Do you want to talk about what
Sure.
Prime is?
PCMH Prime is an accreditation, as you said, that's right now only available in Massachusetts. Duffy Health Center received it in 2017, and it's an acknowledgement that we have completed certain criteria to integrate behavioral health with medical care. It's through the NCQA, which is the National
Council on
Committee
Quality.
of Quality Assurance.
Quality
Right? It rolls off your tongue more easily than mine. Right, worked with the state of Massachusetts to develop these criteria. And basically, it's looking at high-risk patients and trying to get people access into behavioral health, of what you were speaking about earlier. We're very fortunate at Duffy. We have behavioral health, psychiatry, recovery support navigators, and the whole medical team under one roof. A lot of health centers have only a couple of therapists or case managers. We have the whole shindig right there, and we're able to utilize it. So we were able to apply for and achieve the PCMH Prime status. What the process is to identify patients who are high risk, who are seen medically that might need some extra support. We know that there are a lot of medical conditions that overlap with some psychosomatic type things. For instance, somebody who's diabetic. There's a lot of depression in people with diabetes. And if you have depression, it's very hard to follow
To manage your diabetes.
to manage your diabetes. You don't want to be exercising. You don't want to be eating right. I mean, I think we all do our kind of comfort food kind of eating. So you can't treat one illness without really treating the other. So that's why we work together. We also have some psychiatric illnesses that the medications can cause some medical complications. So we need to stay tied tightly at the hip for those patients as well and check their blood levels and all of that. So we're very proud that we were able to achieve
Right.
this status. Yes.
Right. I'm asking this off the cuff. Do we know how many health centers have the Prime status in Massachusetts?
I don't know how many do, but I know not all of them do. I think we do have, an advantage because of the fact that we're co-located, and we have such extensive staffs in all these areas compared to a lot of general
Yeah.
community health centers. But we maybe at least 50%, but not all.
Yeah. Well, it's
Yeah.
really interesting that slides us into the next topic. One of the things that I often say about healthcare for the homeless is that most programs start as a response to untreated medical needs. And over time, working with these patients, we realize the level of untreated mental illness and untreated substance use disorder and the need for housing assistance and case management and those kinds of services. So for example, in our history, we started in the 90s at the then NOAA shelter, now called St. Joseph's House, where we provided medical care on site there and learned about these extensive other needs and became licensed as a mental health provider. And then we did received grant funding from SAMHSA, Substance Abuse and Mental Health Services Administration of the federal government, to really beef up our case management programs and adopt evidence-based practices. The whole thing to say that sometimes just experience with a population helps you understand their needs and spurs you on to create new programs and services. And so working with our patients with substance use disorder, Dr. Klein, there are a number of initiatives that are new that we've been taking on over the last few years, and maybe you can mention a few.
So one of the co-epidemics with the opiate epidemic is hepatitis C. Hepatitis C is a viral infection of the liver, and it's passed through blood-blood contact. And people can get it from transfusions, which they had in the 80s before they tested for it. You can get it through tattooing, but the majority of people that have it is through IV drug use, by sharing needles or the apparatuses that you use to inject drugs. You can spread this virus fairly easy. Also, seems to be some evidence people get it from using paraphernalia to sniff drugs as well, because there's a lot of times some mucosal breakage, bleeding, some of that sort of stuff. So what's happened is that we basically have a co-epidemic of substance use disorder and hepatitis C. About 5 years ago, the hepatitis C treatment has changed completely, the whole paradigm shift. Used to be we used shots called interferon and ribavirin, and these medications were given 48 weeks, and they had terrible side effects, and the cure rates were about 70%. Now we have these 1 pill a day regimens that we treat in 8 to 12 weeks, and the cure rates are in the 97-8% range. No side effects, really nothing. It's really taking basically a pill a day. And so we have 4 of these medicines on the market. A few years ago, we realized that we were doing a lot of referrals to infectious disease, but again, most patients didn't go. And at that time, there was sort of a stigma about treating patients with active substance use and these medications. We started working with Tufts Medical Center, the infectious disease program there, kind of partnered with them, and then we started our own hepatitis C treatment program. And we use a shared medical model kind of to do this. And we treat about 4 to 5 groups of 12 to 15 patients per year. And we've treated about 170-ish patients, and we have what we call cures on about 120, I guess. The reason we can't say more is because from the time you start the med to the time you get the cure is 6 months. There's always a long lag.
So people are in the pipeline.
Yeah, they're in the
right
pipeline
now.
for a long time. You have to wait 12 weeks from the last day of medication before you can even test them again. So it's kind of a 6-month turnaround on all this, but it's been a good experience, and we've sort of gotten heavily involved in the Hep C, I would say, community, which then led us to the idea, well, a lot of people with substance use disorder also suffer from HIV. Again, another thing where treatment has changed dramatically. Unlike Hep C, which you can actually cure, HIV you can't, but they're 1 pill a day regimens, and they're incredibly powerful. We can get it so that the patient no longer has virus measurable in their blood. We call it non-detectable, and the importance of that is they can't infect anybody when they're non-detectable. So we now are treating our HIV patients, our Hep C patients within our MAT program as kind of a wraparound one-stop shop for all of those co-occurring conditions.
And partnering with AIDS support group of Cape Cod
Exactly.
to get people into
Referrals.
treatment very quickly.
They do the rapid testing there, which is wonderful. They do rapid testing, and they can then bring the patient. Then they literally bring the patient over, and we can get them in care. And we did one this Friday. It was really kind of nice because we had a young man, new diagnosis, HIV. We got him on meds that day.
That's fabulous.
And then also got him on Suboxone that day.
Yeah, yeah.
And that's kind of what you want to be able to do, is get people out of crisis and get them on the road to health. And it's also public health, because you're taking that virus out of the gene pool. It's not going to be spread to other people if you can get that taken care of.
Right. Well, unfortunately, we've run out of time. I know we wanted to talk about women's health too, but we'll have to have another show on women's health. I think that's a great idea. How about that? Dr. Wesley Klein, Medical Director, Pat Cawley, Senior Director of Program Services, Anna Marini, Associate Director of Quality Improvement, all senior leaders at Duffy Health Center. And thanks again for joining us, and we'll see you next time.